introduce our keynote speaker or the guest speaker, Dr. Anand Vinekar. And he needs no more introduction. And he is a known figure in ROP, national-wise and internationally. And he heads the pediatric retina department in Narayana Netralaya, Bangalore. And he is the founder and program director of KID ROP, which is a tele-ophthalmology program which has actually changed the way the screening and treatment of ROP is being done. And he has a lot of publications to his credit, including book chapters and journals. And he has been a key member in the new ICROP 3 classification of ROP. And with no further introduction, I would like to welcome Dr. Anand Vinekar for his talk on imaging in pediatric retina.
Thank you so much, and wonderful being back in Kerala as always. So what's new in ROP imaging? I'm just going to quickly talk about the Indian perspective and then end with where we're going from here. So the new classification, the imaging has become so important that in the new classification we are actually looking at bringing in not just fundus photography but other modes of imaging. So that's how important the whole scene is. And this is classically expanded in aggressive ROP. So even that term aggressive posterior ROP, the posterior was dropped because even anterior disease can be very aggressive and severe. And the classical examples of this are only demonstrated by imaging and not just fundus photography, but as you can see here on fluorescein angiography as well. So this whole concept, if you train your eye to this very last photograph below of the angiogram, the blood vessels seem to have reached almost the ora serrata. But there's a lot of capillary non-perfusion going far more posterior. So this is a very severe posterior disease, but appears to falsely look like anterior disease. So that is again where imaging helps you understand. In fact, OCT has also made its appearance in the new classification, but not so much for helping to classify, but otherwise. Now, reactivation is another place where imaging really helps, and reactivation classically is talked about after giving anti-VEGF. So the reactivation can either happen at the original site where the disease was, can happen at a new site which is much more anterior, or can happen in both places. So again, if you have photo documented this in whatever form, drawings, but better photo documentation, angiogram, OCT to show how it's lifted, then it will really help you explain to the patient and safeguard your interests if you are going to do retreatment. Now, what are the newer imaging devices? So after the REDCam, which is considered the gold standard for wide field imaging, we now have the Indian camera, the NEO, which all of you all have seen. This is now commercially available within FDA and CE approval since 2015. But this device now has an angiography module as well, which has now come to market. And what's important here is that as we almost, they say 30% of Indian ROP now is aggressive ROP, which means at least 50% of those or more, we are going to be starting to treat with primarily anti-VEGF. Doing angiography both pre-treatment and to monitor treatment, and I'll show you at least two examples, is very, very useful because you don't know when to intervene as far as the retreatment is concerned. And then there are other low-cost devices which also do the job. They help in photo documentation, maybe not in a telemedicine model as yet, but these cameras that have been made by the Agarwal and the Gujarat group, these are modifications of your 20D using a smartphone. They work bedside, they are useful in photo documentation. Now I'm going to talk about angiography in the realm of anti-VEGF because that is where it's really important. So this paper coming from the Chinese group showed that there are at least 3 or 4 different patterns of how these blood vessels grow and then stop growing. So there is a vascular arrest. So we know recurrence, we talked about recurrence and reactivation. But there's also something like these blood vessels have started growing to a point and then they don't grow any further. And that's when you have to take a call to do the laser treatment or in very rare cases maybe re-inject. So these patterns are now described and some of these patterns mimic something else. For example, in our Indian ROP Society group, there was someone who showed a sort of a telangiectatic nodule in the periphery 5 years after giving anti-VEGF. So, and it almost, many of them, like a spotter said, this could be Coats disease, this could be ephemia. So, all kinds of abnormal findings are beginning to emerge after anti-VEGF, and it's really important to document these because that's when you know when to do the treatment. So for example here, it can be as bad as disc leak right there in the posterior. It can be as peripheral as a proliferative, as though it's a regular stage 3 in the lower column. So these are all that's been described. I'm just sharing a couple of our own cases here. So this is like a very bad posterior zone 1 aggressive ROP, which was given Avastin, bevacizumab. 10 weeks later, the plus is gone, all of that's gone, it's doing well. But almost 3.5 to 4 months later, there is a very bad, very posterior vascular arrest. The vessels don't seem to be growing any further than this. Now, there's a debate on whether you can give a second injection or not and why it's not usually preferred. But at this point, when you have this picture, which looks so innocuous, you can hardly tell what's going on in the periphery. You can hardly tell that more than half of the retina is literally bleeding with avascularity or ischemia. So angiogram helps. And that's when you have to complete it with a laser. There are now guidelines going to come out shortly, how long to follow up and when to do the treatment. Now this is 3 months after injection. Both eyes had a recurrence, with one eye having a notch recurrence, as you can see here, and you have to go in and treat it. We've tried avoiding the notch and waiting for further growth, and we find that another 3-4 months later you have to come back and treat the notch, and this time unfortunately maybe under sedation, because the child has now become 10 kgs. And then don't think that all recurrences are symmetric. For example, both these occluded avascular retinas, aggressive ROPs were given the same injection on the same day, but one comes back with a recurrence right there, almost looking like an early 4A, like child misses follow-up and comes with a horrible looking recurrence in the left eye, whereas the right eye looks very innocuous. The blood vessels are just going forward. So of course we treated the left eye immediately, and the right eye 3 months later. We were hoping that the blood vessels will grow further. They grew a little bit further, then ended up with persistent avascular retina, which was eventually treated. And this was the final outcome. Now, I just want to show you here that despite one eye having vascularization almost till zone 2 anterior and the other one having that 4A picture right there at zone 1, their vision is equal. The refractive error is almost equal. So one often thinks that, oh my god, if I do very posterior laser, I will cause a very high myopia or I'll cause all of these issues. This is just to show you that, of course, this child has undergone a lot of vision rehabilitation and so on. It just didn't happen by accident. But the point is, at the end of a year, the vision is equal. And the refractive error is also comparable. Now this is what happens if you inject and laser but incompletely. This was treated elsewhere, came to us as a 1.5-year-old child. So you can imagine 1.5 years after giving injection and laser, because it's done incompletely. Look at the picture on the right. Would you worry that this is going to be as bad as this on the angiogram? Maybe not. So now coming to OCT. So OCT, I've just spoken about this a couple of weeks back, so I'm going to go a little faster on this. That today we are able to do an OCT of a baby who's a few weeks old and look at all the layers that are coming or not present and then correlate that with vision. So that's really important, and histopath studies have shown what we are seeing is what's actually happening. For example, the RPE is right below, but on top is the ellipsoid zone, which is growing sequentially from 38 weeks as a single layer to a 48 weeks when it becomes a 2-layer. So that means this baby was not born with this layer, it came after some time. And our attempt has been to see whether any of the delay of these processes has correlated with any poor vision or not. Similarly, we found this macular edema, which is now called macular edema of prematurity, which is very transient, happens between age 37 weeks and age 50 weeks, but which can correlate with vision even at the end of the first year, can cause slight hyperopia at the end of the first year. So this has been our attempt to look at some of these events that are either delayed or not happening and correlated with vision. Similarly, OCT angiography has been a new tool. This was our very first case report where we looked at the new vessels that were not just on top but were also deeper, and we are able to look at a slightly older cohort, and these are 3 groups. One group that had no ROP, one group that had some ROP that went away, and the third group is completely normal. So and you can see that all of them, despite having 6/9 or better vision, they still have abnormal looking foveal avascular zones. So normal ophthalmoscopically, normal visually, but structurally abnormal. And it all goes down to their OCT changes and OCT angiography changes as well. We are also now able to check the contrast of babies few weeks old and correlate that using these special paddles and correlate that with vision at the end of 3 to 6 months. Universal screening through imaging, you are not only able to pick up for ROP, but other conditions as well. In this study, up to retinoblastoma, that was in preterm babies, and this is a universal study paper where we found that about 6.8% of conditions that require treatment were picked up in the first 72 hours of life if you do it. Imaging can also be used to train people across borders. And I'm going to finally end with machine learning or artificial intelligence. Today, India has done a good amount of work in ROP AI. We are now to the point where we are able to look at an image, segment that image, figure out whether this baby has a stage or not, and integrate it with a telemedicine approach. So this is really going to help. For example, this is a machine telling you that the picture on the left could be a stage 1 and a stage 2, and the picture on the right could be an early stage 3. This is a machine telling you just by feeding in the devices. The accuracy is good, it's not amazing, but this is yet work to be done. So, thank you so much.
Thank you, Dr. Anand, for that wonderful talk. Any
You
questions?
don't need to do it under GA, but it is done in the OT with the anesthetist standing by. So our IV access is obviously important because we are giving IV fluorescein. Some of my friends have tried the oral fluorescein, not very useful in aggressive ROP. By the time it comes into the circulation, it's very tough. So just exactly the same precautions that you would take for laser, you would take for angio.
Any special cases where you would prefer doing an angio, or do you do it in which
We are now
cases?
doing it for almost all cases of aggressive ROP. We try to do it if we are, injection is our plan of management. We try to do the angiogram a day before because we feel somehow we are contaminating the field by running the camera over the eye. So we do it a day before and then take the baby into the OT straight away on the day we are giving the injection or following day later.
Before the initial treatment?
Before the
Initial treatment or?
unfortunately, we don't have too many of those because these are very sick babies directly come in for the injection. But we have almost for all of them after they have been injected and before we do the laser therapy.
At the time of recurrence?
At this time of therapy.
In some babies who have a spontaneous regression of ROP, but they tend to have persistent avascular retina, do you recommend FA in such cases?
So the recommendation now is if the persistent avascular retina is more than 2 disc diameters, one has to do the treatment. If it is less than 1 disc diameter, then you don't have to do the
Yeah,
treatment.
but ROP has regressed, like no ridge.
Correct.
You just have avascular retina.
So that is a problem. So now there is a definite recognition that avascular retina is a problem because as other studies have shown, they have a 14 times higher chance of retinal detachment as young adults and as adults. And it literally becomes an FEVR now. You've sort of converted the phenotype. So laser is a definitive therapy. The point against giving another injection at that time is that, see, another injection will only further reduce the VEGF load, which is already very low. Now you want VEGF for the blood vessels to grow. So giving another anti-VEGF is counterintuitive. So laser is, the only difference between doing laser in PAR and doing laser primarily is that we have not found the blood vessels growing over the lasered bed. Whereas if you do monotherapy with laser, you almost always find the vessels growing into the lasered area. So that is sad, but if there's a way to maybe reduce the anti-VEGF dose and do a titrated dose, it might work.
Thank you.
What maximum time do you prefer to treat such babies where there is a PAR?
So I'm talking on behalf of the society. We are now trying to come up with a guideline saying 48 to 52 weeks or 4.5 to 5 kgs. There's some rationale behind that, we can discuss that later. Or if your facility has like, okay, I will do it under general anesthesia, you can push that for way longer. But if you are the kinds who will say, I want to do it under topical, 4.5 to 5 kgs or 48 weeks minimum, unless there's a recurrence. So we're not talking about recurrence, we're talking about PAR, 48 to 50. Yes, correct. So the Samira Kori case, if you are there in the previous session, in that you cannot combine a diagnostic consent with a therapeutic consent. And clearly FFA is a diagnostic consent. So definitely yes. In fact, we can't even take the adult angiogram consent that's there in our hospital. We have to take a separate one. 0.077 ml per kg is the dose.
And sir, about the universalized screening, what is the government of India suggest now, like for routine eye checkup you need for, not for ROP?
So under the RBS scheme which came out in the 2013, they said universal screening should be done.
Not all should be done like.
They unfortunately don't have operational guidelines for non-ROP conditions, so it's left to us. So our program where we are doing universal in Karnataka in the government hospitals, just to give you a sample difference, we have covered about 220,000 ROP sessions, but we've covered just about 18 to 20,000 of universal screening sessions. So though it has not caught on even in the government sector, which has made it mandatory. But it is definitely something to think about and talk to your pediatrician about.